Friday meeting of the OHDSI Phenotype Development Evaluation Workgroup. We have a packed agenda that I proposed today for your considerations, and the agenda is posted here. I'm sharing my screen. It should be. Trying this out for the first time to see if the Microsoft Teams channels work. Okay, there you go. So the agenda for today is this standing item, welcoming any newcomers. To have a group discussion, we would like to hear your reflections for a total of about 5 minutes about Phenotype February. I would like to go through the status of the phenotypes. We have an idea of attempting to discuss the phenotype of adult dermatomyositis today. Then review some other action items that we talked about. Mr. Jacob Zelko has proposed to a checklist, and we want to review the status on that. And also he has an idea that he has reflected on, so maybe we could hear that. Regarding Fabricio has worked very hard on a solution for modeling a complex clinical idea. So he's going to talk about it for a few minutes. And then we have some action items on the phenotype of anaphylaxis. So these are the proposed agenda items. Any other items you would like to add? I see, Jamie, you have your hand raised.
Yeah, just at the very end, I'd like to propose the paper that I'm planning to draft from the OHDSI Symposium last year, where we all worked really hard on the acute pancreatitis phenotype, and we ran cohort diagnostics and p-valuator across a large data network for that particular, actually for 5 versions of the phenotype. So I think that could be something we could all decide who wants to work on, who wants to do what, and line up a a publication activity there. So I'll just present that briefly at the end. There's not too much more to it than that.
Okay. Okay, awesome. All right, thank you, Jamie. All right, so starting out. Anybody else? Any other agenda item? Okay. Any newcomers who are absolutely new to the work group, have never heard of this work group, and would like to introduce themselves?
Oh, hi everyone. My name is Fong. I'm new to the group. So I'm working at Amgen in the US, and in my company, my team is supporting the department with the use of Atlas, and our team has been developed concept set and a cohort for different disease and products, and we are interested in building a standardized concept set to support the whole department, and that's why I'm very interested in joining this group to learn and hopefully can contribute to the team as well. So very nice to meet everyone.
Very nice to meet you, Fong, and welcome. Welcome to the community and welcome to the work group. You will find that this work group has several resources that you could potentially use in your organization. Follow up to your comment, how long have you guys used the OHDSI stack in your organization?
It's been more than a year, but I just joined the company for a year, so it's just a short experience for me, but I'm willing to learn more. Yeah.
Excellent. Welcome. Okay, anybody else?
Thank you.
Okay. All right, so let's start our group discussion, the main agenda item. As you all know, there is something called Phenotype February going on. Is there anybody who's like, what is Phenotype February? I've never heard of it and are in this work group right now. Okay, that's good. I mean, any thoughts, reflections on how is it going?
There's a lot of good discussions going on. I think everybody's doing good stuff.
Gautam, maybe if you share your screen with the status of the phenotypes, yes, then that brings memory to people of what has been discussed.
Okay. So we have, as you all know, it was discussed in the previous work group calls. There is under the general channel, there is a folder called Phenotype February, and we maintain some documents to help us. And there is a document that I'll open, which is called the tracker. And it in Teams, sure. So as you all remember, we are tackling 10 phenotypes for the month of February and 4 discussion topics. The 10 phenotypes ordered in the degree of complexity starts from the acute pancreatitis, anaphylaxis, appendicitis, and acquired neutropenia. They were part of the week 1. And then systemic lupus erythematosus, acute hepatic failure, and adult dermatomyositis, which is part of week 2, followed by Parkinson's disease and ST elevation myocardial infarction week 3, and hypoxic ischemic encephalopathy among neonates as part of week 4. The reason why they have been ordered in this fashion is the first 4 were previously developed and evaluated, but needed an independent peer reviewer to review it and provide their input. The order of work and time is expected to be lesser, and so we said we'll do 4 of those. The next one was the systemic lupus erythematosus, acute hepatic failure, and adult dermatomyositis. They were previously developed by somebody, but they were not subjected to a systematic evaluation or peer review. So the task for the week 3 is to evaluate them and subject them to peer review. The Parkinson's disease and ST elevation myocardial infarction were never developed. So they had the clinical idea, but no core definitions were developed. So as part of this effort, there is core definitions being developed. They are being evaluated, and they will be part of a network study. They'll also be subjected to peer review. And the last one is hypoxic ischemic encephalopathy among neonates. This is an end-to-end process that starts from defining what the clinical idea is all the way to full peer review. So that's the framing of Phenotype February for 2023. Does this jog any memories? Anything that you want to talk about? Any specific reflections on any particular phenotype, or just the whole process? Do you like it?
I remember last year. I'll start to getting people. I remember last year. Gautam, can you mute yourself? There you go. Thank you. I remember we posed that question in the and we were almost at midpoint last year, and everybody was talking about how long the posts are and how maybe it's hard to follow. I don't think we changed that. The posts are still long, and there's pretty. I mean, we don't have as many as last year, but there's still a lot. I don't think we got the engagement we are hoping for. So, and maybe part of it is the length and the complexity of the posts. But for Gautam and I have been thinking about this and how to get more engagement from people who are not necessarily in the weeds, like many of you are on these specific phenotypes. But it's challenging. So we're curious to hear your opinion about, like, as somebody who hasn't worked like close to acute pancreatitis or anaphylaxis or appendicitis, when you were reading this books, how could we encourage interactions on the forum?
I'll chime in. Are you guys able to hear me, first of all?
Yes. Oh,
great. I'm in a bit of a different location. We have no water at our house. It's been a week, man. I think the forums are. I think it's just a challenge with it's not so much the interest, but maybe the time that, in that time interest integral that people struggle with. I really. I know that the calls don't necessarily offer the kind of the artifact that's in a post that is persistent. But I think you guys have done a really good job of engaging people through the calls, and that might be kind of the gateway drug to broader engagement in the community and in the forums eventually, because I think it brings people along in a way that's a little bit more natural than they're able to do by jumping into the discussions.
I see. That you brought up a very good point, Evan. What we have done this year, which we have not done before, is recording some sessions and showing the evolution of the thinking through the recording, transcribing those thinking into a forum post becomes very lengthy and also difficult.
I would just, sorry, I'm relatively new to all of this, and I would just second that comment. I agree with basically everything that was said. The forums are incredibly valuable, but it's a little bit like drinking from a fire hose, especially if you only have, 45 minutes in a day to kind of figure out what happened that day. So the videos are very helpful. I agree.
I've had a little trouble accessing some of the materials depending on where I am. So for example, last night I was trying to access some of the forum posts from my phone, and I kept getting redirected to all the 2022 phenotype work. One of the pages has click here to link to 2023, and you click and it redirects to 2022. So I've had a little bit of trouble accessing the different forums and accessing the launch pages for 2023.
That's thank you for sharing that perspective, Andrea, and I'll verify that with Craig Saxon, who's maintaining the website. He is in the process of creating a landing page for Phenotype February 2023 with the links, and I know there was some issues with that, so he's still working on it. But I'm hoping that there will be a landing page for Phenotype February 2023 on odyssey.org with the links to all relevant content. If you see an issue where the label says 2023, but it is linking to 2022, please let me know and I will have it fixed.
Awesome. I'll see if I can pull it up here.
I think having a landing page will at least help people access everything in one spot versus now you actually have to go on the forum, maybe put search terms related to the phenotypes. So you have to know the phenotypes that we're working on, or try to do phenotype 2023. But I think if we have one page that has the discussions on the phenotypes as well as the discussions on the methodological discussions, as long as all the recordings and the trainings and all of that, I'm hoping that that will help people get to where they want and at least get visibility and engage if they choose to.
Right.
Maybe Gautam, once Craig get this running, we make an announcement and link to people, because people who are very far from what we're doing are still, I think, finding it hard to find where in the forum. And it's because it's not one spot in the forum, it's across multiple posts.
Yeah, so I'm going to pull up just because of the conversation. So I'm going to pull this page. This is an unpublished page, but this is the landing page that has been designed, I believe, Phenotype February 2023, and there is the weekly updates will go here, and this is supposed to link to individual posts. Oh yeah, there it is. That's the videos, including a brief synopsis of it. So I think he's still working on it. I don't know if it's been promoted. Maybe the promotion will go out today.
Yeah, if you change 2023 in your URL to 2022, there should be a link there in the middle of the page to visit 2023 homepage right up at the top. And that keeps redirecting to 2022.
I see. Got it. Okay, so that's he's probably has kept a placeholder without updating it. I will report that. But in terms of the 2023 page, it should redirect to this page, and it's not doing it at this time. Okay. Thank you, Andrea.
Sure.
In terms of the depth of the content, one of the feedback that we received last year was that the depth of the content was not sufficient, and we as a group decided to go, more comprehensive and deeper into every phenotype. What do you all think about the content? That if you had a chance to review the content, what do you think about the content that was covered? Was it useful for you? Did you have any suggestions to improve? All right, so I want to take a few more minutes just to talk about the status of the individual phenotypes, and then we'd like to go to specific phenotypes. So
And
we have.
just before you start, and that will take this an opportunity, since we do have many people on the call today, to see if we can get engagement on finishing some of the final steps for the phenotypes that are pending, few things, especially those that require revisions, so we can get them to completion. So
Yeah,
keep your ears in case you do want to contribute. We're gonna offer some options to complete some of this work.
Yeah. So in terms of every phenotype, there are a few phenotypes. So in this spreadsheet, obviously the first column is the ID, and then there's the name of the phenotype. And I have individual owners of it, followed by the current status and next steps. So the first 4 phenotypes, these 4 phenotypes, I've named the reviewers as the owner. Notice I did the evaluation documentation. I just did not put my name as the owner, because then it will be just my name all over, which would kind of look stupid. So in terms of the status for acute pancreatitis, Evan has proposed some changes. I think they have reviewed the request that Evan has made, and I think it is feasible. I would like to ask if there is anybody in the community who would be interested in volunteering a design to address what the ask that Evan is proposing.
So
that
to
be
be
a volunteer
specific,
other than me?
Yeah, I mean, it's you are welcome. You will be the owner of it, but Evan, we would see if anybody else is wants to be involved with you to design that.
Yeah, so to be specific, Evan, you have proposed specific possible changes on the algorithm itself. And so the required work would be designing those in Atlas, implementing those changes as alternative definitions in Atlas, and go through the process of evaluating what do we see in terms of numbers, in terms of, so it will need a run on cohort diagnostics, and that's something that Gautam and I can help in. And then we will need to look at the evaluation. But currently, we need somebody to help lead with you implementing those changes or like those possible algorithms in Atlas, and then we'll work together to evaluate with the against the proposed definition and either accept the original one or one of those updated algorithms. So if anybody, because I know somebody did made a forum post on acute pancreatitis that they are interested in joining. And also it is the one that Gautam submitted is technically, Jamie, is the same one that we worked through the symposium with the very minor modification. So it could be a continuation for the symposium if you guys want to wrap it up. If Jamie, if you want to wrap it to your work, and this way, when you write about this work, it would be like we evaluated those different algorithms, including the ones that Evan proposed, as an iteration to the one we started with during the symposium. So that could be so you and Evan, and of course, will help to just fully evaluate acute pancreatitis.
I will use all of the content that we created during the symposium and this nice submission that Evan has put together that Gautam and you and everyone has helped with, and it will constitute the bulk of the content of the paper. I'm just going to be the person putting it all together into a deliverable.
So as another, to make this more sweeter, and to make it more attractive, there is a high probability that this work will end up as a peer-reviewed scientific paper. So if you want to be a collaborator in a potential peer-reviewed scientific paper, this is your opportunity.
Yes, and later on, at the end of this call, I'll get whoever's on the call that wants to participate. I'll just solicit your emails and get everybody on one list so that everyone that wants to participate and can contribute will all be on the same thread.
That's right.
So why don't you put Gautam for the owners of the next steps would be Evan and Jamie Weaver, and speak up right now if you want to be part of iterating on acute pancreatitis. Anybody interested?
And again, just while we're on it, I mean, while we're on it now, rather than waiting to the end, there are definitely some analytic tasks that could still be done in order to make this thing even more complete. But I'm going to, at this point, move forward as if we have all of the analytic output ready and just start writing the paper. And Evan, if you and I want to, find some time to get back into our muck of doing Phevaluator on the STAR database, we can do that. But I think at least for now, we've got Phevaluator results from 5 databases, cohort diagnostics from like 14, and it's a lot of content for one phenotype that I think will really help people trust it if they want to use it across the network.
Yeah, the only thing is that it'd be interesting to see what kind of impact you might think there might be in the iterations that have happened.
I agree with you, but I'm also considering how much we've done and how much more there is to do in this phenotype and many others. I also think getting one to done is important. Like making this type of approach of phenotyping a valid, accepted, publishable type of paper is important. And I think that
100% agree.
And the amount of work that we've done is sufficient for a paper, in my opinion. But I mean, some reviewers might argue with that, but we'll give it a shot with what we've got. And if a reviewer says, "Oh, you need Phevaluator and STAR," then we can, get back to our hacking session and try to do it.
No, I'm more thinking about the changes in the actual definition itself, which are, so it's iterated since the symposium, but 100% agree around the desire to get something out there.
Right. I don't think for the purpose of this paper we should incorporate the changes from the definitional changes that you have made, unless you really put your foot down and try to convince me otherwise. But we can talk offline about that rather than with the whole group.
Sounds good.
Okay. So David
has his hands up. You want to join that work, or you want to ask?
Well, actually, I already volunteered, but it was for the anaphylaxis one, I think. And so
you're on the list for anaphylaxis.
Yeah. Okay. So, but I mean, happy to help with the acute pancreatitis. And my comment actually was for this potential paper that Jamie was referring to, and Evan. If the paper is going to focus on the development of this specific phenotype only, and how useful is acute pancreatitis phenotype in federated data network analysis, or whatever the focus might be, or we are focusing on the process. So how do we develop a phenotype in the context of OMOV common data model, something that it's useful and applicable beyond the 14 databases or 20 databases or whatever.
So my vision for this is to definitely include that there has been a development component, but the focus of the paper is going to be the evaluation. We're going to say, like, here are these tools that we've used to show that these definitions adhere to the clinical definitions from these authoritative sources, and we don't just show it wishy-washy with characterization results, but then we actually quantify it with the Phevaluator in the databases that we have available.
Great. I think it's a wonderful opportunity to just start setting this best practice guidance, and so happy to hear that. Thank you.
Yeah. So Asa, you have your hand raised, and then Patrick.
No, actually, I'm gonna let Patrick speak first.
Patrick,
yeah. I just want to chime in about David's comment there. So there's been various conversations about this, and I'll just want to share my perspective. I think we are greatly discounting the value of writing a paper about the phenotype of an individual disease. Currently in the peer review literature, there are papers that are called things like development and evaluation of a phenotype for, and then fill in the blank of a disease. And yet almost all of those papers don't adhere to even a minimum set of what we would consider to be current practice. Most of them involve one organization evaluating one data source, maybe doing some sort of chart review of questionable description, providing one algorithm that's just an ICD-9 code list, and then just saying, like, here you go. And yet currently our own practice involves starting with saying, search the literature to find an algorithm. So I actually think that the biggest opportunity that I see is for us to be writing the papers that say development and evaluation of phenotype or blah, where what we're doing by putting out a series of papers is, number one, providing the reference that can support the individual phenotype, and the methods of the paper then allow the opportunity to describe the best practices, showcase the use of multiple databases, showcase the use of various tools. I actually think that will be exponentially more impactful than just talking about writing an informatics paper about a generic process. I mean, we should do that also. Aza and Gautam have one drafted from J&J, and I'm sure this group will come up with other papers to write about that. But I strongly hypothesize that those will have much lesser impact than if we can write if Andrea can write the paper on here's what we've learned around the world for how to do anaphylaxis, that will become the reference paper for anaphylaxis. And if Weaves can write a paper that says, like, this is what we've learned about pancreatitis, that will become the default starting point for pancreatitis. So I think that those papers are a really great opportunity. We may not do all of them, we may not finish them, but I think we would have a bigger impact in the field of phenotyping if we get clinical subspecialty journals to have papers that describe a phenotype following the OHDSI process and like kind of pepper the area than we will if we just have one paper that's just an opinion perspective piece on a process that we've come up with.
And just to follow up on that, we've the systematic reviews on development and evaluation of acute pancreatitis, for example, is just like a smattering of stuff where none of the sensitivities or negative predictive values or basically any of the approaches to get these measurement errors from the different sources is inconsistent across all of them. So that we've got 14 in one shot using a standardized practice is a pretty nice addition. I think it'll be valuable to get out.
Yeah, no, I mean, don't get me wrong. I didn't mean to undermine the value of publishing the acute pancreatitis and the specific disease phenotype evaluation and development. My point is that we as a team are going in the direction of developing a standard way of developing phenotypes and something that becomes useful over and over and kind of having and strengthening the possibility of repurposing these cohort definitions instead of going from scratch every time. And for that, we wanted to create a process that validates to some extent, or at least evaluates the validity and the applicability of a phenotype across different databases, not undermining the value of a single disease phenotype development and evaluation, but I think we should at least consider the idea of setting what are the minimum that we want to set as the things that we want to put there in each of every paper that we publish within this group or any other in the OHDSI community that creates this. It's true there is not something like this done before, but there is somehow some sort of when a validation study is published, right? They have to publish certain minimum criteria on the design of the study, on the analysis of the study. How did they evaluate? What was the gold standard? All those things have been, if not established in a way like a process, but as the best practice. And I think my point was only that we should take the opportunity also to establish a little bit of these best practices and not undermining at all the value of individual diseases. So sorry for the misunderstanding in that regard if I didn't express myself well.
No, I think David, go ahead, Asa.
I was just going to suggest that maybe as part of this and as part of follow-up on the working group is to have a publication plan. Because I think it's not only David, there's many people, you and I know, many people are asking us, and whether it's on the disease specific or is it on the approach itself, method kind of perspective informatics. So let's have a publication plan that states who's going to lead what and what's going to be the objective.
When we started Phenotype February 2023, we said done is the developed and evaluated and into the OHDSI Phenotype Library. Let's create a stretch goal for Phenotype February and a goal for 2023, which is we have a publication plan for each of these 10 clinical ideas, a lead who's going to take that to completion. It's a stretch goal for Phenotype February, but I would say we have a named person for acute pancreatitis, and I saw Andrea's head nod for appendicitis. What do you think? There you go. Appendicitis.
Oh. Appendicitis or anaphylaxis?
No, anaphylaxis. You're doing anaphylaxis, correct, Andrea?
Yeah.
Yeah.
No, I would not lead. I would not lead. No, I'll definitely help, but I'm happy if somebody with clinical inputs on appendicitis who would like to lead, and I'll definitely support. Keep it open. We'll come back if if Evan,
if you guys put me down for that.
Yeah, sure.
Right.
I'll bring it to the peri-op and surgery work group.
Perfect. Neutropenia. Neutropenia is something you're working on, right, Aza, as part of designated medical events? Is that what you want to continue?
So we have neutropenia. So full disclosure, we have worked on 27 outcomes internally in J&J. They are called the designated medical events outcomes that are related to pharmacovigilance. Those are clinical events that are considered serious enough and may be related to medication use. So whenever they triggered in a safety system, surveillance system, they need to be followed. So we worked in J&J to phenotype all of those for our internal work, and we're publishing a paper of those phenotypes that we did. And acute pancreatitis is one. Sorry, acquired neutropenia is one of those. So it is included in another drafted work.
Anybody else is interested in joining Aza? This is your chance. Systemic lupus erythematosus.
Joel, yes.
It got accepted for publication this week. Should be out soon.
There you go. Awesome. Congratulations, Joel. Acute hepatic failure. Dr. Christian Reich is the owner of it. I've sent a reminder for him. His post was due earlier this week. Maybe there's some delays, so we'll follow up. Acute dermatomyositis. We will be talking about it in just a few. Hopefully, we have time. Christopher, Dr. McCauley, do you think you can continue this work to an attempt to make this into a publication plan?
Absolutely. Yeah, one of our main goals on our side is to kind of distribute this into the rheumatologic world clinically to try to increase uptake with other academic institutions that we partner with.
Excellent. And I know Dr. Booth wants to pursue this as a publication, and also is Dr. Mirza Khan on the call?
Yeah, I'm here. I'm down with pursuing that as well.
Excellent. And I believe Kaiser Aziz also would like to, but he's not available this week. So Evan, you're trying to help him, correct? Because he's on the service.
Yeah, I built out a few candidate algorithms for this, and just having to connect with them to kind of confirm. I'll post something today just to keep the conversation going on it. Okay, great. Okay, so we have a publication. We'll be developing a publication plan as part of this work. So in keeping up with the agenda, so we want to talk about the status. We want to go ahead.
I'm jumping to anaphylaxis. So that means because David is following with Andrea. So David and Andrea are, I'm assuming, taking the lead on the publication. David will be, because he's implementing the iteration, correct, Gautam?
No, David has offered to execute the study, unless David, you've changed your plan, execute it on data sources as a data partner. So we still need volunteers to step up and help with the core definitions. I have not heard anybody. Evan and I were hoping to make progress on it if we don't hear any other volunteers. So after this call, at the end of this call, I was going to propose that we spend half an hour. If anybody was interested, I was going to spend half an hour trying to convert the proposal. So I proposed a design in the post, convert those designs into Atlas compatible cohort definitions. Evan has made progress on it, and we're just going to convert that, move that forward.
Yeah, I've done the X1, X1A, and the X2 I've finished. But there's still some uncertainties there to visit, so we can focus on that on the call.
Yeah. So, anything else on these 10 phenotypes before we go into the phenotype of the day, adult dermatomyositis?
I guess just a quick question is I've seen a couple of meetings come across for dermatomyositis and Parkinson's, but I haven't seen any meetings for myocardial infarction. Are there meetings for each phenotype that we can join?
Yeah, so yesterday, I believe, I set up meetings at 9 a.m. Eastern Time, 10 a.m. Eastern Time, and 11 a.m. Eastern Time using the Microsoft Teams environment. The 9 a.m. and the 11 a.m. went broadly, but the 10 a.m. just went to Dr. Khan and me and one more person. So unfortunately, when we collaborated and worked together, nobody else got the invitation except us. And that meeting was recorded, so there is a YouTube video on it. But with the moving forward, we'll try to, it's something that happened, absolutely no explanation to it. I just stopped sharing my screen because I'm doing setting up something. Dr. Macaulay, would you like to update the group just in a few minutes what has transpired in the past week?
Sure, absolutely. So we have developed our clinical idea of adult dermatomyositis and posted that in the forums page. A lot of our time with our team, Zach Wang and Will Kelly, has actually been troubleshooting our local environment here at Hopkins. We've had a lot of issues connecting to cohort diagnostics and Evaluator, but I'm fairly certain this is our institution's problem. So we've tried like several workarounds with the help of Gotham and others, and I think we're kind of approaching a final solution there to actually be able to run cohort diagnostics. We had a call earlier this week to broadly review some of the cohort definitions that we developed, and a lot of good suggestions were made in terms of tweaking those cohort definitions. We had two in general. One was sensitive, one was specific, and we had some, good results with the sensitive, but everything basically went to zero with the specific because we had included a lot of lab results and test results requiring not only the test to be performed, but also to know the results. So based on feedback, we kind of tweaked to that, and that's kind of bringing us to today.
Right. And thank you so much for that, Jacob. Go ahead, Angelo.
I'm sorry, Christopher, are you interested in doing Evaluator at your site on this?
Very much so.
Okay, let me start working up the cohorts to sort of give you a leg up on what you need, the cohorts as input for Evaluator, and we'll work from there.
That'd be wonderful. Thank you.
And Joel, I have
yeah, Gotham. Just to divide and conquer, because I know you're helping a lot with all the other things. So maybe Dave, Joel and I can start thinking about Evaluator, and Joel, I know, is already thinking right now, probably with the inputs, and then we can connect with the team on Hopkins.
Yep, excellent.
Does that make sense?
So let's go through the core definitions really quick, just to understand what the definition is. I have received the core JSON specifications from Dr. Macaulay and his team, and I've imported them into an Atlas instance. So I'm going to pick up just very quickly, show the definitions. So there are two key definitions. One was both developed at Johns Hopkins University. One was called as dermatomyositis sensitive, and the idea of the core definition logic for it was based on a condition occurrence of dermatomyositis and requiring two occurrences of dermatomyositis. So basically, you have to have one dermatomyositis today and another dermatomyositis within 1 year of today. That's the implementation. The second implementation was what was described as a specific definition. That specific definition went through iteration. In the initial version of the specific definition, it did not yield any record counts in any of the data sources, and the reason was that it was dependent on an antibody test result, and that antibody test result did not yield any hits. It could be because of several reasons, including that antibody test was not observed in any of the data sources, or because it requires the use of a result, and the result being positive, and that positive could be represented in many different ways. The configuration of the definition did not lead to hits. So it's specifically this particular rule here. The rule said you in addition to requiring immunosuppressant therapy, you need to also have a positive test result for an antibody test, and these antibody tests are specific for this disease. So that's when we executed this particular definition on data sources in Johns Hopkins University and some of the data sources that I have access to. We found no records or very little records. So today,
did you check the vocabulary, the concept set values for this, if it's truly positive, or those that did you look at the not raw data, but did you look at the data? And
yeah, so in some of the feedback that we gave to Dr. McCulley's teams was like this. This was pointed out by Andrea. So units by volume is not represented as positive or negative. Units by volume is a quantitative number. So there was discoveries that we made that was provided as a feedback, and it's all in that recording. So today they offered a new definition, and the new definition is still a work in progress. So that new definition is the presence of an antibody test. So if you have an antibody test, you would be allowed to enter. So this would not be affected by the points that Andrea and Asa you made, which is the quantitative versus yes or no, positive or negative kind of test result. So so you just had this definition developed early this morning. Are you still working on the definition, Dr. McCulley, or are you okay with this definition as is?
I mean, this is maybe fine for instructive purposes, but this is not the final definition. We're definitely going to have to tweak it further.
Okay. Gautam, may I suggest, if you're, I know we have many things on the agenda, but we could use 10 minutes. You guys ran cohort diagnostics on the sensitive definition, or so-called sensitive definition?
We did, and I was running core diagnostics, as you can see, on the specific definition. In terms of the sensitive definition, it is posted on data.odyssey.org. So if you go to data.odyssey.org and scroll down to Phenotype February P7 dermatomyositis, you will see the output of the first iteration. Here we have the original sensitive definition and the original specific definition. The original sensitive definition is still the same. The specific definition is the one that is currently being worked on.
So we can take 5 minutes on cohort diagnostics for the sensitive one. That can give the team an idea of at least that population they're capturing, basically the people who have 2 diagnoses, and see if they really wanna, they think that there's more specific, but we can already see the presence of measurements or tests among these people, the one we're capturing with 2 diagnoses. That will give us an idea of what will happen once you go the route of all these rules that they're thinking of. So we can spend 5 minutes, look at what kind of patients you captured by requesting those 2 diagnoses to start with.
I'd be real interested in seeing the treatment on day 0.
Yeah, so you can see treatment, we can see the actual presence of these tests to have an idea of what, like how much you're going to go down in numbers when you start requesting any of these events.
Yeah, Joel, regarding your comment about treatment on day 0, this is a very complex and difficult disease to diagnose, from my understanding. In other words, just like the systemic lupus erythematosus example and the forum post and discussion with Dr. Alhambra, it is possible that there will be that the testing for the antibody and the diagnosis of the disease would be off by several days or even weeks or months. The reason is it takes a lot of build up for a clinician to be very confident that they actually have the disease. Is that a fair comment?
Yes.
Yeah,
So my
what we
question-
look like, what we look for evaluator in the XSpec, the extremely sensitive, extremely specific definition that we try to do, is while a lot of databases don't support multiple diagnosis codes within a short period of time, what we're looking at is if they had a diagnosis code and a treatment on the same day, we're using that as if somebody has a diagnosis and a treatment on the same day, it's pretty indicative that person has a high probability of having the disease.
Understood.
So like for this one, yes,
So yeah, right now if I just search like a generic antibody, I see these tests, and I don't know what these tests are. Extranuclear antigen antibody, and about 12% in one data source had it on the day of diagnosis, which I think is much higher than what you would expect in other diseases. So that's pretty promising. For the forum post on systemic lupus erythematosus, I basically selected this option, which is any time prior to any time in the future. The assumption is if you go back, I guess, 30 years and go back forward 30 years, you should be enough to cover a person's lifetime. And this is the sensitive definition. So the assumption here is that there may be people in this cohort who do not have the disease.
Oh yeah, let's not get hung on the naming, because there are two codes that you're requesting. So
Sure, yeah. So if this concept is representative of the antibody testing, then in one data source at least it says 46% of the people had this test at least once in their entire observation period.
you also have, I believe, you also have other concepts that sound semantically repeated. You had the antibody screen.
Yeah. So
You have
this is just one code. When we add up these individual relevant concepts, the proportion may go up. What I don't know what these are.
Yeah, I mean, this makes sense. I mean, whenever, I'm sorry, Andrew, go ahead.
Oh, sorry, I was going to say the ENAs are a really common panel that you'd expect to be run with the evaluation of dermatomyositis. So I guess I'm looking at this and I'm curious, are most of these labs mapped at the panel level instead of the component level? So the LOINC codes that we're using here are at the panel level?
It depends on how they came, right? It depends on how they came. So they came as a panel, you're gonna only see them as a panel.
Oh, okay.
It's not a matter of mapping, correct, Patrick, if he's still here?
Yeah, I was just gonna comment. So when we see measurements, they're not necessarily LOINCs. In the OMOP CDM convention, anything that is potentially a measurement, regardless of whether it induces a value, goes in our measurement table. So in this particular case, you're seeing an example of a CPT4 code that is indicative of measurements taking place, and that's actually the indicator that we're observing. So it's not always necessarily LOINCs, and it's not always necessarily with a measurement.
Oh.
With a value specifically.
But that seems like a really important point for me to understand then, because in general, all these things are panels. No one's ordering individual myositis antibodies. So that's a really good insight. Thank you.
Yeah, and just to be clear, this is totally source data dependent. It's not anything to do with the CDM. Like from a healthcare process perspective, clinician's going to order a panel that's going to induce a CPT for it to get reimbursed for the fact that that panel is going to be done. Then the lab facility is going to send back individual results for the individual tests that happened within the panel. The question basically at the source data becomes, do you see both ends of that transaction? Do you see the order come through at the CPT4 code, and then do you see the lab values come back, which could be like at the at the LOINC level? In the two databases that Gautam's showing here, like Optum DoD specifically is a claims database that happens to have a partnership with selected labs like LabCorp and Quest. So if a person had a qualified plan and went to a LabCorp facility, then we might see the lab value come back in that data source. But there's a whole bunch of ifs. If the panel is something that would actually be processed directly within the hospital system or at an outpatient visit or whatever, then that data wouldn't necessarily be reflected there. In contrast, the Optum EHR data source is a different data source. We're seeing things that are in the EHR, which means if it was done within inside of the network of practice that data set represents, it might be there. But if somebody went outside of the health system to get the laboratory test done, then he would not observe it. And I'm going to imagine, Chris, like at Johns Hopkins, you're going to have yet another different circumstance for whether or not to expect to see that.
Yes. Yes.
But that doesn't change our core definition logic, because the core definition logic seems to work because of the way the vocabulary and the concepts of expression would work. It would still work for a data source that has the lab results represented in LOINC or the lab results represented in CPT4.
But what this is showing us, if you build a logic that you require the measurement to just happen, a lab to just happen, just like what you just, I think Gautam explained in the current specific cohort that you're working on, not looking at the value, but looking at the fact that a measurement took place, and you included that particular code, and you opened up in time, then you expect to cover at least something around 50%, at least in one database, or 23% in another. That is the proportion of people who would make that requirement. If you don't start looking at the values, and as Patrick said, the problem with the values of the individual value, it depends if it came back or not, and if it came back or not, depending on which data and where the measurement took place. But you know that the measurement was requested as part of a panel in this case.
Yeah. In terms of evaluation, though, what this is showing you is that people in this cohort are being tested for the things that you expect them to be tested. And that's a good sign. And that would show, it will be an indicator of some form of a specificity for you and a PPV. It's not a quantitative metric like p-evaluator would provide, but it is showing you the attributes about this person's. Is there any other attributes that you would like to look for these people? Treatments of any kind? That is.
I mean, you could. Prednisone is probably the most sensitive drug to try. Rash is probably the most sensitive symptom to search for.
Mm-hmm.
Would you say for drugs, prednisone?
Correct.
Maybe Gautam show us the entire, instead of searching for a drug, just let's look at the drugs prescribed. Maybe you want to switch to on the day off or around the day of index.
Prednisone, and as we learned from some of our early testing on that, excluding topical preparations.
Yeah, so now we're looking at the data on the concept ID level. So we will see, yeah.
So this is on the day off. So on the day of diagnosis, it appears about in one data source, 13% was started on prednisone, and there's use of methotrexate, hydroxychloroquine. Is hydroxychloroquine used? I know it's used for rheumatoid arthritis.
Yes, this all tracks. I mean, I think you would have to extend the time window in which you look at this, but this all makes sense to me.
Yeah, so this is a very restricted implementation. So this is called drug era start. So that means that the person is actually starting it on that day. It does not count persons who are already on the treatment on that day.
If you add your time zone to the -30 and the other two, the 30, it always allow you at least to look around the day of diagnosis.
So what did you say about topical? I missed that. You don't count topical?
Well, there are just a lot of them, a lot of them compared to it, and that's not a drug that a patient would typically be put on. So if we include topical, then we pick up a lot of patients that are probably outside of that cohort.
Okay, so this suggests again in a qualitative way that these individuals seems to have the treatment that you expect. There might be again people who do not have the disease, but we don't know how much that is quantitatively. Are there any attributes that you would not expect these people to have? If present, would you say that's not?
Think of differential diagnoses, things that don't co-occur. And Gato, maybe you want to look at conditions.
Yes. So there's a lot of codes of eruption.
Yeah, so actually I found, I don't know if that's a mapping thing, but I do find from other phenotype, the idea of rash and skin ulceration, I found that the code eruption is what's used to represent it, but it might be mapping to some more specific term.
Yeah. So hypothyroidism, is that a red flag for you by any chance?
No, I mean, this whole list kind of makes sense to me, to be honest with you. All these diagnoses are enriched in these patients. You know, they're usually 50 to 70 when they're diagnosed, although it's a huge range. So you expect things like high blood pressure and diabetes. A lot of those signs and symptoms, you know, are seen with a heterogeneous rheumatic disease, including other autoimmune diseases like Hashimoto's and other causes of hypothyroidism.
Great. Great.
And I see muscle weakness, which is not something that usually pump up on the top unless. So you see some skin manifestation, some muscle weakness manifestation.
Yeah, I mean, this all tracks to me. I think the thing I'm struggling with at the moment is like the order of magnitude. So I'm seeing these percentages on those columns, and I mean, it makes sense that they're there, but I'm treating them almost as like binary, like yes, no, but I don't know what to make of the fact that like there's 10%. Yeah, whereas in my mind, I'd want maybe a higher number, but I don't know where that falls into, you know what I mean?
Absolutely. So let me answer this question in twofold, just because we've been doing this for 2 years. One thing to keep in mind, these percentages are only representing one single code. They're not representing all, let's think of eruption as a condition or symptom. They're representing one code that is called eruption. Usually an event or a symptom or a disease or a measurement is usually presented with a set of codes. So things add up. You're currently just saying that one code that happened to be repetitive, so comes up to like 10 or 20% among the people. Usually when you create what we call the feature, where you put together all the codes that represent a certain event of interest, and then you look at its proportion, then you start getting closer to that number you expect. Because currently things are dissected to the code level. And so like you're looking at a very small proportion, maybe small, maybe big, we don't know, but you're looking at the one way of measuring eruption, only one, and usually it's not one code, it's usually a set of codes. So that's one reason why you don't see numbers super big. The other thing is, yes, this process is very, you're looking at these numbers and it's hard to make sense of them because like what exactly you expect, and then are they small or are they big? I think that's where Phe Evaluator comes with a much better concrete way of telling you what exactly are you observing among these people. Because actually the way we evaluated build that gold standard is by looking at the distribution of these events that happened among people you believe truly have the case. So in that case, maybe eruption in that population that is very, very specific going to be higher, but you don't dictate that, the data dictate that, because it looks at those events, those people that you believe truly have the event, and it looks at the distribution of these other events, and then tell you, okay, now you're proposing this algorithm. I'll tell you how much those people in your candidate algorithm actually had these events that we saw among the people you truly believe had the event. So it will quantify that for you in a predictive model, versus us trying to say, well, yeah, I think 10% is good, I think 12% is good. You don't know. But if you tell the model, the prediction model, that I truly believe those are the cases, then it's going to look at the distribution of these events, or the distribution of the events that are more common for these people, and then set that gold standard of what that value should be. And then it's not going to look at one factor, it's going to have a prediction model which will have the entire set of a vector of these events that happened. I don't know if that makes sense, but like you should always look at these numbers more of like, does it make sense to you? Is it in line with expectation? Rather than like, oh, it's 10%, but I think it's 20%, because one, you're looking at on the code level. Second, your mind can't really wrap up all these crunch numbers, but a predictive model can.
Very helpful. Thank you.
Are the lack of covariates an issue that we should be concerned about? For example,
Absolutely.
in this population, we would expect about 40% of them to have a comorbidity of interstitial lung disease. However, it seems pretty far down the list before we get to the first incident that could be related, which is dyspnea.
Yeah, so if you see here the
But this is
proportion
only
for-
30 days. That's only 30 days.
I was going to say that, yeah.
Yeah,
Okay.
you probably want to look, yeah, and you might want to look at the pretty table, because then you have, do we have a lung? I think we have a lung disease, don't we have?
Yeah.
Isn't there a SNOMED group?
not interstitial lung disease, but I think there is
And that would
something-
make sense. If we're only looking at a 30-day window, that's something that would likely develop
Yes.
later.
Is it later? Okay, so Gautam, you want to look, yeah, minus 99 to plus 99.
So I
And
went-
again, this
I
is a
went-
code. That particular disease you're interested maybe has a distribution of way that it's presented, but.
Yeah, so here you see, if you look at the entire lifespan of the person, 15% of the people in one data source who had the diagnosis of dermatomyositis had interstitial lung disease.
Okay, that makes sense. And that makes sense that even if they presented with it, would be diagnosed early, since most clinics that don't, it would require pulmonary function testing. And I imagine most rheumatologists a referral to a pulmonologist, which would, of course, take some time. So, okay.
You were expecting 40%, just for me to.
What was your expectation? Just curious.
Oh, go ahead, Chris.
Honestly, I'd probably be closer to these numbers that I'm seeing with dermatomyositis. Again, there's so much like caveats here I could say, but you know, this is in the ballpark for me.
Okay.
Yeah. Okay.
Any other risk factors or any other things that differential
look,
diagnoses?
Is there a easy way of looking at cancer? These patients have an enhanced risk of contemporaneous cancer, so I'd be kind of curious to see.
Do you have any specific malignancies? Like again, this is the there are so many different types of malignancies, and
yeah, breast and ovarian are the most enriched.
And actually, Gautam, breast, yeah, you actually have a breast in the pretty table. You have a neoplasm of the breast as a group on its own. But that's going to tell us at baseline. So not in the future, but up to the point they got that diagnosis.
Got it.
So not much.
Not much. This is indexed on the time before, right? That is dermatomyositis considered a risk factor for breast tumor, or is it the other way around? So which comes first?
It's a bell-shaped curve around dermatomyositis onset. So cancer occurs mostly within the 6-year period surrounding dermatomyositis onset.
Well, you see a good chunk of breast lump.
Yeah. So what I think we are observing is in this data sources, it is shifted after the index date. So it needs to be confirmed, but just a crude look, this code here, which shows that in the 365 days prior, so 1 year prior, I think it's 1 year prior, right?
No, it's look back. It's all time.
Okay. In the time before their diagnosis, only 1.2% of the persons had breast tumor, and it's for both genders, so it's not restricted to female gender, for example. And when I look at the raw table, so we usually say pretty table and a raw table. In the raw table, the similar concept has much more higher prevalence, not 1.2, but like 12% at least, maybe higher. And that suggests to me that the bell curve is shifted after index date.
Got it. It's really interesting.
Do you see this often in patients that are actively being treated for malignancy? Like in the times I've seen it, this kind of jives with, and obviously I'm not a rheumatologist, this kind of jives with when I feel I've seen it, as a perineoplastic manifestation. Then you might find the cancer, as opposed to an existing cancer that's undergoing therapy and then they develop dermatomyositis. That's just not a timeline I've seen, but you would have seen it, and I wouldn't have.
Right. I guess it kind of depends on your vantage point. I feel like oncologists, might see these patients differently than rheumatologists and dermatologists. But in general, about half of the cancers are diagnosed before dermatomyositis, and then half are after.
Interesting.
The thought process is the cancer is driving the development. So whether it occurs before or after, that's the idea.
But it's more how it manifests in the disease, or how it manifests in the timeline. Like the cancer might be driving it, and it may have pre-existed, but it might not be discovered until after you have the dermatomyositis. In which case, in the data, it would show up after.
Exactly.
So remember that you are requesting 2 codes that have the second code happening after the first. So you might be, because of that design, you might be having a delay on the time that you're announcing the person as having the disease. So that number with cancer might actually, those people might have cancer before, but because you're waiting till you see that second diagnosis, so you're biased to you're slightly you're shifting yourself to the left a little, to the right a little bit when you put that index date, and that might why you see the cancer happening after.
That makes sense. Yeah, we were kind of trying to thread that needle of a mortal person time requiring that second diagnosis.
Yeah,
it could also be selection bias if these 2 particular data sets include oncology centers where they may get that, where they may be visited first and have that malignancy diagnosis afterwards versus the other way around.
Yeah. Okay, so we are way over time already, but this has been a very interesting conversation. Any more discussions on this topic?
Before you go, I think, have you guys checked I know everybody's worried about specificity, but I usually worry about sensitivity as well. Have we checked that we captured the full set's potential codes? Are we good in terms of that index, the way we're capturing people? Could it be that there are people with the disease that have a different code than the one listed?
So this is an adult dermatomyositis. So when we looked at the recommended system with Dr. McCauley in the recording, there was a few codes like childhood type dermatomyositis that was not considered to be part of this clinical idea. So an attempt was made to review to make sure that it is comprehensive.
Can you click on just lexical via source? Okay, and this is just this code. The one you're starting with is just the code itself, right?
The conceptual expression is basically verbatim codes without
So
expression.
I think you might have a mapping issue here. Go back to the recommended and lexical via source. There's something that maps to these. I see childhood type dermatitis makes sense, but why is it recommending that first one? That first one must be mapped to some source code that have dermatitis in its. Yeah.
This is extremely helpful. Thank you, everybody.
And then the one thing you want to look at is your attrition by that second code. You want to see how much you lost by requiring a second code, especially in diseases that are like specific, like by their nature, right? Or like it's not a common thing. It's not hypertension or diabetes that a physician might be giving the code for rule out or like. So you want to know how much you lost by requiring a second diagnosis, just for you to know what's the potential loss in sensitivity. If it's 90%, you really want to ask yourself, are there really, that many people having the code one time and disappearing and,
So filtered by standard to non-standard map.
So here you see the M3390 point. That's a read code that you're missing. I see that.
Other diameter. Oh, here. Oh my God, I don't know how you can see that.
There's actually more. Yeah. So it looks like you guys might be missing those. Just see where they're mapped. They might still be mapped to something you included. Like that doesn't mean, but now you're gonna see the opposites. And I click on them and see if they're mapping to a standard that you already included. Okay.
It is mapped to dermatomyositis, Aza.
And you have that one. Okay. So it's 1-to-2 mapping. That's why it just recommended it. Okay.
Yep. Okay. So we could, as you make progress, Dr. McCall, if you want any assistance from this group, we can set up another session and do a review. I have executed the definition that you shared with me this morning. It was not ready for this review, so we only reviewed the sensitive definition. And also in terms of the construct of sensitive versus specific, we can also think about maybe reframing the terminologies.
That doesn't mean anything. I guess it's the attempt is to get to a narrower that you have believe in. Before we, Jen, I'm taking these notes because we need those for the peer reviewer. Can we look at the attrition, how much we lost with the second diagnosis?
Yeah. So I'm gonna go to the two data sources.
Not bad. So we have
30%.
Okay. That's not awful. So most people indeed have a second diagnosis.
This was the one that had the most loss. And we don't see anything here because there was really no hits. But this was the definition that included lab results of an antibody test. And that's basically, there was only one data source in the 11 data source that led to, but I don't have the results for, I could do it. I can show it if you guys are interested.
No, hold on. Look at incidence rate. What do you guys have as
incidence rate is not being shown because of the software issue.
Gplot. Okay.
Yeah. But I could show that on my local instance. Takes a
any estimate of what do you think is the incidence in a US population?
10 per mil to 50 per mil.
Okay, just in that bulk. And were the codes present in both the ICD-9 and ICD-10 world, or is it something that came? Okay, so we should see a nice stable line in terms of like.
Yeah, I guess so.
Okay, we can look at this on your local later Gautam. But in terms of logistics for Phenotype February, so we are, Astia was expecting an evaluation from us, but we're not ready, which is totally fine. So maybe you want to communicate that we're still working on it. I can, if you guys are fine with that, I can post on the evaluation on the forum the progress we made and that we looked at the first candidate cohorts and we observed some of these things. The things we observed today, I can summarize it just to put it up there.
That'd be wonderful. Thank you. And then we clearly have some work to do on our side still. So we will definitely be in contact. But thank you guys so much.
So I have the output. We'll discuss that at a later session. Okay, so we had other agenda items. Do we want to continue the conversation? I know Dr. Wu wanted to hear about the progress Fabricio has made with FIA, but I don't see him on the call. He did post that on the discussion forums. So do you want to give an update to everybody, Fabricio, because you've worked a lot on this already?
We are very over time. I'll post on the forum the text.
Okay.
So Gautam, we need 2 more meetings. We need a meeting with Fabricio and Dr. Wu about particularly this topic, and then we need to catch up with Chris on the so we keep this moving.
Acute hepatic failure. Yeah. All right. Thank you so much, everybody, for attending the work group session today, and looking forward to the next meeting. The next meeting will be the 4th Friday of this month, so I believe it will be when is it? February 24th. So meanwhile, please engage with Phenotype February 2023.
Just one last comment before we go. I'm going to write in the Teams channel here a request for anybody who thinks they've sufficiently participated to meet the ICJME guidelines to participate in the acute pancreatitis paper. So if you want to participate, please raise your hand and I will make sure that you're included in all of the correspondence about that as it starts to develop.